First of all, thanks to Dr. Anand, Dr. Molidhar, and VRSI for giving me this opportunity to share this case with you. So, if my slides are visible and I'm audible.
Yes, yes, go ahead.
Perfect. Yes.
Yeah. So, this patient is a 57-year-old diabetic and a hypertensive who came to our clinics, and his visual acuity was 20/80 in the right eye, 20/40 in the left eye. And if you look over here, the left eye has some evidence of a temporal vein occlusion as well as steroid hyalosis. But what was surprising was this excessive pigmentary changes which we saw in the right eye, and these seem to be over the surface of retina. This was not intraretinal when we looked at it carefully. We found this to be basically covering this area. And when we did an OCT, the left eye had an ERM, some distortion of the structures over here, nothing surprising. But the right eye had this pigment, this hyper reflectivity over here, as if this pigment was interspersed with the vitreous phase over here. This was more like pre-retinal. So we were surprised as to what we were dealing with. One of our thoughts was, is it a PFT with an abnormal pigmentary changes over here? We went ahead, did an OCT angiography. Again, though the left eye did show some terminal dilated bulbs, which could point towards a possible PFT. The right eye, again, most of the changes were obscured by this pigmentary changes. So there was this layer of pigments, which was essentially obscuring our visualization of all the underlying details. And so we thought, let's do an angiogram and see what does the angiogram reveal. So if you look over here, even the autofluorescence, and then the subsequent angiogram also, again, the same problem. This pigmentary change is obscuring a lot of details over here. The left eye, though, did show some evidence of an underlying PFT. So at this point of time, we thought there's no underlying membrane. This is just a pigmentary change over here. Let's observe this patient for a month, see how is it evolving. Is there a further deterioration? So now this patient comes after a month, visual acuity is still 20/80, 20/100. But the patient is not at all happy with that observation. And we are also at this point of time at a loggerhead as to what we are dealing with. And since this was pre-retinal and there was nothing else which we were thinking could help in the management, I thought, let's do a vitrectomy, remove this. If needed, I might even need to do an ILM peeling because probably this is pre-retinal. So I went ahead, did a vitrectomy with the intention of doing an ILM peeling. But to my surprise, all of these pigments just came up. The moment I induced a PVD, they all lifted along with the vitreous. So this was just over the retinal surface. And all of the pigment just went away. I did not even have to resort to doing an ILM peeling. And so we were wondering, what is it? I mean, if you go back and look at literature, we know that there are intraretinal pigmented changes in PFT, but those are intraretinal. All of this was pre-retinal or over the surface. I will not go into the theory over here, but at a month, if you look over here, now this is the picture at 1 month and subsequently even at 2 months time, pardon this artifact, but all of those changes have gone away. And now when you do a OCT over here, now you can see these changes over here, this foveal atrophy, these changes over here. So now we know for sure that this was probably a case of PFT, but my questions are, what was the cause for this abnormal pigmentation? Is it an end stage proliferation presentation? Is it that the pigments have migrated from the inner retina to now pre-retinal or above the surface? And why did they occur? And would we have been able to manage this a bit differently, or what could have been the other options in this case? And with that, I close this case for discussion. Thank you.
Thanks, Mudit, for a very interesting case. And we do see these kind of, very aggressive proliferation sometimes and these pigments in mactal cases. So I'll come straight to you, Vas, your take on this. That surgery was a bit of a dare, but well, it looks like it paid off at least anatomically.
Functionally also.
Functionally, what was the outcome? You said.
So at post-operatively, right now, the patient 2 months later has a visual acuity of 20/60.
Okay, that's better than where you started off with?
Yeah, we started at 20/80, 20/100. 1 month down the line, now it's 20/60.
So congratulations again. That was a bold move and paid off. Nothing pays off. Nothing succeeds like such. So, Vas, over to you.
Yeah, very impressive case, first of all. As is correctly pointed out, I think, these pigment plaques, we think of commonly as being interretinal or possibly even subretinal, but we often don't think about them as being epiretinal, which seems to be the situation here, where the RP cells made their way to the retinal surface. The other thing you have to worry about is, just as the neovascularization associated with MacTel tends to be or is subretinal. There was a nice case reported from India, I think in ophthalmology retina last year, I think, of an epiretinal neovascularization case associated with MacTel. That's unusual, much like this sort of very prominent epiretinal plaque. And so I was very happy to see the OCTA, because that would have been the thing I would have been most worried about. It was in case there was some early neovascularization that actually had gotten into the epiretinal space as well. Then you would worry when you tried to peel it whether you would have other complications. And so, as Anand pointed out, certainly a bold maneuver really seemed to be helpful for this patient now that you have this additional follow-up. But I have to say that I have seen a lot of MacTel cases, never seen one with this prominent epiretinal pigment proliferation as in this case. So I was quite impressed by it. I have seen other cases with some degree of epiretinal pigmentation, never one with such an extensive plaque. But I applaud you for the management here and for doing that. I might have been scared and sort of watched this patient, but I think clearly your maneuver seemed to help in this particular case. But as I said, I'm glad the OCTA was performed to exclude the neovascularization on the epiretinal surface.
Yeah, and additionally, I like to say that it's a good thing. There's a wise move not to try to peel that ILM, because then that would have been deleterious. So, Dr. Muna, your take and comments on this.
Yeah, thank you, Mudit, for showing us this nice case. I think some of us have seen such patients whom we are following over the years, and vision generally tends to be stationary. I have tried doing an OCTA in them at the vitreoretinal interface to see if I could pick up vessels. And I've never been able to pick up vessels, but somehow always a little hesitant to suggest surgery in an eye with macular pathology, because you don't know in the long run how much atrophy will worsen. It has happened to a patient with Stargardt's, where I removed the ERM and I found that eye became worse over years, whereas the other eye remained good. So my only concern would be the long-term outcome. The foveal atrophy is more evident now than it was earlier. But otherwise, yes, a very brave move. I think helped by the fact that you did not find neovascularization on the OCTA.
Yeah. Dr. Shukla, yeah. Yes, Dr. Shukla.
Yes. I do not have much more comments. Actually, the points have been made clear by Dr. Vaz and Dr. Mona already. So, as Dr. Muralidhar has mentioned, Mudit, have you done the cuts of the octa a little superficially? Because to make out what Vaz was saying, the epiretinal neovascularization, you have to make the cut superficially.
I did that, sir. I did. And I extensively checked for any neovascularization before we went ahead.
Great. So the other thing, like I have operated some case of combined hematoma of the retina and RP. So they have the similar, pathology and the similar dilemma. You have the pigment on the retina, which could be extending downwards actually. So the only thing that you do during surgery is to, peel it carefully. And if it is not coming off, just leave it actually. That's all. There is nothing more that you could do, but you came out well, and it looked like a epiretinal pigmentation. So it's a pigmentary epiretinal membrane, which is not an anomaly. It is seen in some cases, but the pigment is huge. So probably the pigmentary epiretinal membrane was made more pigmented by the migration from the retina, but fortunately it had no subretinal or intraretinal connections. So that's what made you lucky, and good management.
Yeah, Rohan, you have a quick comment on this?
Yeah, Dr. Mudit, very bold surgery. Actually, I have seen a patient like this in which the pigmentation was significant and bilateral. So our first diagnosis, like yours, was also maybe a PFT itself. But then while we were searching for differential diagnosis, I just found one image. Can you allow me to share the screen, please?
Yeah, sure. I'll just stop my share. Yeah,
so
I've done that.
What we found was that such significant pigmentation has been shown in oxalosis. So I'm not sure whether it is that, but if you can see this picture, so that was one differential we had considered. We did check for the oxalate. You see this sort of image? Yeah. And then there was one differential given of a congenital dystrophy with a lot of pigmentation bilateral. So these three things we considered.
Okay. Okay. That's interesting. Dr. Muralidhar, are there any questions from the
No, no
audience?
questions from the audience. I think the points have been well covered. The OCTA of the vitreous has already been done by Mudit, and he was not able to see any epiretinal neovascular membrane. So it seems to be a rare case of a pigmented epiretinal membrane. And having been associated with PFT, you're always worried whether it's a retinal pigment or intraretinal pigment or the epiretinal pigment. So the bold move to do the surgery did really help the patient in this rare case.
Yeah. So Jay, we'll move to you. For the
Nothing much to add from my side. I think something very interesting which Apurva from India reported about the epiretinal membrane, the way you guys discussed about, I think ruling that out was very, very important. But I think something more interesting is that why did the pigment started moving towards the membrane? And I think this is a question which always there in our mind, that the fovea started thinning out much faster after the membrane peeling. So that also remains a worry. And I think one very important point which came out at the end from Dr. Rohan Chawla was keeping a differential of oxalosis. And I think this is a very, very interesting case. Mudit, you should start thinking of writing this up. It would definitely bring up a lot of interest from the readers. Thank you so much.